you, David, and I'm excited to chair this session today. As you can see from the title that I just changed, it's about AI in health, the promises and perils of AI learning from healthcare data. Today's session has 5 outstanding panelists, 4 faculty and 1 PhD student representative, and it's going to be a session that we may say it's different from usual. We're going to talk about what doesn't work in AI at the moment in healthcare. And I will just proceed to introduce our panelists. Then we will have structured discussions. So we will have some case studies presentations, and all the panelists are going to tell about their research and their engagement in AI in healthcare. Then there are some prearranged questions to the panelists where the public can also interact. And eventually, at the end, if we have time, there could be free questions from the audience. Just a quick introduction about myself. I am a professor in the Department of Epidemiology, although I'm a computer science engineer by training. So I've been grafted about 15 years ago in the colleges of medicine and public health, and I fell in love with applying AI and machine learning onto healthcare problems. I'm also serving since last November as the Associate Dean for AI and Innovation and the College of Public Health and Professions. My research interests obviously are machine learning, prognostic and diagnostic modeling. Interestingly, I'm developing causal AI, which is a novel field of artificial intelligence. We're going to learn a little bit about that today. And my field of application is infectious disease modeling, especially bacterial infections and viral infections. You will have our contacts here. We also will leave some business cards for later if you want to grab them. Our next panelist is Dr. Chantrelle Candidate. I had the honor to be her mentor since a while now, since a few years. She's a recent NIH K01 awardee. She has been awarded other research projects from the NIH on AI. Currently, she's a tenure-track assistant professor in the Department of Epidemiology. She also serves as director of the Riser Lab, Reducing Health Inequities so everyone can rise. And she's also the associate director for outreach and community partnership at the Emerging Pathogens Institute at University of Florida. Her research interests include health disparities, health equity, HIV and substance abuse, obviously AI and machine learning methods, and women, reproductive health, and research on dementia. Our next panelist is Dr. Simone Marini. He's also an assistant professor in tenure-track Department of Epidemiology. His research interests are very close to mine, AI, machine learning, antimicrobial resistance. We work on several projects together, data integration, and other virus-related research. Next in line is Dr. Serena Guo. She is an assistant professor at the Department of Pharmaceutical Outcome Policy, so a different college of pharmacy. And, but we work together also on projects. And her research includes AI, pharmaceutical outcomes, equity research on applied fields like diabetes and neurodegenerative disease. I also know Alzheimer's and Parkinson. The next one is, I think it's been, well, 2 slides have been flipped. Okay, I will introduce the PhD student representative, and I will leave our fellow panelist as the last. Sarah Serre, I am her advisor. I hope there was not too much nepotism today in choosing this representative, but it was chosen because of the themes. So she's a PhD student in the Department of Epidemiology, and her research interests include iatrogenic conditions, antimicrobial resistance, computable phenotyping, this is interesting, and research on electronic health records and causal inference. And then, last but not least, Dr. Jihong Lee. She's a professor in the Department of Biostatistics. She's also the director of the Division of Quantitative Science at UF Health NCI, just recently NCI designated Cancer Center. She's an amazing researcher with well, outstanding track record in many years. And she's a biostatistician. She's expert in cancer trial design, good statistical practices. She will talk about best statistical practices today. And I love these. Democratizing statistical knowledge by making statistics understandable and accessible for all. I think this is a beautiful statement. Okay, so let's go into the case studies today. I call them case studies, but it's really knowing about the research of our panelists and how they can exemplify the promises and the perils of AI in healthcare, because this is the theme of our session today. So we will dive first into AI perils, and then we will see what are the possible solutions, our hopes to make it better and functional and working. And we have a common thread that we will go along. So we will start actually on a reversed view. We start at the end. We start by hypothesizing that we already have an AI system that is to be adopted. And we want to know what are the people's view, what are the people's perception about that. So this will be our first use case, and it's about acceptability of AI. Usually this is the end. We start with that, because this is the first thing that we have to make sure. And then we can look into the details, into the methodologies, into the theory, into the problems related to the development, the modeling, the coding, and all the technical stuff. The first thing we will look at is going to be data. AI feeds on data. So do we have issues with data? What are the issues with data? The second one is, okay, maybe we have solved all the data issues. The AI now is a system that makes predictions. It's going to forecast the future, and it might be used to change the future. Do we have problems with that? Are there problems that we have not thought about? So that's the third subtopic. And then finally is, okay, we have an AI system. We are learning more and more and more from the data. We are actually solving prediction problem. We are making sure that the prediction, the forecasting do not produce more harm than intended. What happens if these systems are hacked just for the sake of getting the results that we want? Because that is also a possibility. So these are going to be the 4 subtopics where we are going to discuss in terms of problematics inside AI in healthcare. And then we're going to see how we can avoid them, and if we can write down and create guidelines to avoid such pitfalls and have best research practice. So I will pass the stage to our first panelist, Dr. Chantrell Candidate, and her case study is about acceptability, implementation, and usability of AI. Thank you.
Hi, everyone. Can you hear me okay? Can you hear me now? Yes. All right. Great. So as Mattia mentioned, I conduct a lot of research among people living with HIV, and most of my research encompasses mixed methods. And so with this particular case study, I was working with Mattia and Dr. Salimi on a grant looking at the development of an AI novel software tool that was predicting the ability to forecast future HIV trends in Florida. And so between October 2021 and March 2022, my team and I conducted a series of focus groups among key HIV stakeholders. These included public health personnel, individuals, people who identified as HIV advocates. So these were attorneys, case managers, disease intervention specialists, as well as clinical providers. So kind of understand what was their acceptability, how did they see Pride could be useful, and whether or not they had insights as to how we could implement this type of software in Florida. So some key points from these focus groups was that overall, participants expressed high acceptability of Pride. They were excited about something that was being developed, but they also had concerns about the ability of Pride to cause unforeseen or unintended consequences, such as HIV stigma, which is really, really prevalent here in Florida. With regards to implementation, participants expressed concerns about making sure that there's some sort of training for those who are going to be users of Pride, but also training for those who are receiving Pride outputs on how they can use that information in the communities that they serve. There were also concerns about the fairness and whether or not Pride had the ability to exacerbate disparity among groups, and what are the concerns that we can do to mitigate any additional concerns, such as the predictive analysis piece of Pride, as well as how other people could use it in their communities with limited resources.
Thank you very much. So if we want to summarize these key points, we know from these discussions that the AI system should be usable, should be robust, we don't see cases. It should minimize harm, it should be fair, and it should be trustable, both in terms of privacy and governance. Yes. Thank you. So let's suppose that we're doing a good job, as Dr. Candidate is doing, and we are making the acceptability component taken care of. So let's go now into the actual development of an AI model. The first part is learning from the data, making sure that the data and the models are reliable and interpretable. So Dr. Marini, what would you tell us about that? No.
Does it work? Yes. Okay. All right. So our AI models, it goes without saying, learn from the data, and traditional, although a little naive approach, can be to say, okay, I have to develop my AI model to solve problem X. I will now gather all the data that I can find about problem X, make a rich data set, and let my AI learn from that. It's still done. It's still the default way to put together the training sets for AI models, but this approach doesn't come without problems. And the problem is, what if there's something wrong with the data? The AI can learn anything from the data, and it will learn the errors and the problems along with them. So this can be true for any AI application, from self-driving cars to optimizing selling musical instruments. But for health data is particularly problematic. And there are all sorts of biases that we find when we use data, as it normally happens, that have been collected by someone else, when we put together all we know about the problem X. And that depends mostly on the fact that the scientific community is more interested in some problems than others. And then that goes for example, for population with some maybe ethnicities or age groups that can be more represented than others. It can be due to the fact that some therapeutic targets are more famous. There is more money to research some of the targets and not all of them. There can be heterogeneity in the sampling because of the convenience of sample collection. And all this can be summarized, as I said, in a sort of bias by design due to the fact that we are analyzing secondary data. We are using data that are being collected for other purposes by someone else to train our AI. So what are the consequences? Well, there are several. Most of all, that an AI might not be able to properly generalize, might not be reliable outside the statistical distributions of the data that it has been trained on. And for that, of course, it's always recommended to validate the prediction of any AI model in completely external data sets. So, for example, if we want to make an AI that predicts comorbidities in diabetes, and we train the AI on data that we have put together, we can save some of them and use them as an external validation set. Ideally, data that have been collected by in a different place by different research teams on the same problem or about the same problem. Some AIs are not readily interpretable or black boxes. Typical examples might be a neural network, and one of the problems with that is that once the AI is trained and it takes a decision to make a prediction, it's harder to dissect why the AI went on one road instead of choosing the other. And I can't see the slides. Sorry. Now I will thank my colleague for sharing. Yeah. Okay. So I will now.
The second one.
Yes. We can move to the second one. Thank you. So this was very general, and I will now. Thank you. I will now show you a couple of examples that I found in my work, in my research work. So, for example, in the case of drug discovery, I worked on AI that makes prediction about proteases. So you might have heard about the CRISPR-Cas9 and genomic editing. These are proteins that cut the DNA in specific part, and we want, since it's very hard to figure out how and why, we want to use AI to predict where the DNA can be cut, rudely speaking. The point is that some of these proteins are very well studied, such as Cas9, that's the base for the CRISPR technology, and others are not. And if we do not take this into account, we will end up with an AI that will be very good in predicting targets for very well-known proteins, but not as good for others. And this has implications in the development of novel protease techniques. It is hard to expand this. And again, this comes from the fact that the data are collected from the scientific work of researchers all over the world through published papers, to databases, ontologies, and so forth that are biased. Another example is in antimicrobial resistance, so resistance to antibiotics, for example. I worked on that, and I made AIs that will predict if a specific bacterial strain is resistant or not to an antibiotic. And this is important because we want to avoid giving an antibiotic to a patient with an infection that is resistant to that antibiotic. Now, when the AI learns how to make this prediction, the AI is based on, again, everything we know, everything we could put together about this problem. And I am one of the authors of MegaRAS, which is a very large data set of known antimicrobial genes and genomic variants. And 53% of them are all related to one large antibiotic class. Now, I'm not criticizing Megares because I'm criticizing my own work, basically. But Megares is a fantastic tool. The problem is that, again, some infections, some resistances in antibiotics are more studied than others, and this is reflected in the data, and in turn, this is reflected on what the AI will learn. Okay, conclusion. Thanks. Conclusion. On the left, I show you some papers that I published where some of these problems are patched. And they are patched by addressing these biases, like calling them out, figuring them out, and finding a way to rebalance either the data directly or the learning process, for example, by weighting the different samples. But, as I said, these are patches. The real systematic solution would be to plan ahead. First of all, not using secondary data. Secondary data are super precious. Okay, no, I'm not complaining about secondary data. I'm a data parasite myself, but we should think about collecting the data for the purpose of training an AI. And in that way, we could inherently avoid all these biases at the data collection point. I will conclude here because I talk too much.
Thank you. Yes, you are going over time.
Of course.
So I think that one important take-home message here is that we need to avoid bias, because bias is inherent in the data. Black boxes are not easy to interpret, so it's very difficult to spot such bias. And another important point is that AI can be used also as, rather than a hypothesis testing method, as a hypothesis generating method, because we can't really be sure what we have in the data. So regarding the bias, we're going to pass on to the next panelist. I just want you to remind that this second important point is about hypothesis testing, hypothesis generation, because AI can test millions and millions of such. So that is going to be the contribution of Dr. Lee. But let's dive into bias and pass the microphone on to Dr. Guo, which will talk about when prediction is not enough and AI can be used for intervention.
Thank you very much for coming to our panel. In the next two slides, I'm going to talk about counterfactual prediction. In the slides one, I want to address the issues of general prediction. In the biomedical and healthcare field, AI machine learning has done really outstanding job to help us to predict the risk of disease and outcomes and determine the strong predictors. However, most of those prediction models are developed using observational data with some nature of confounding and bias. So it's one of the common problem of general prediction is that the predictors are not necessarily causally related to the outcome. In other words, if we put intervention on the predictors, whether it's going to improve the outcome or not, it's unknown actually. So in these slides, I'm going to address why we cannot use general prediction to identify effective intervention target. So there are two common causes of bias. One is confounder, the other one is collider. On the left graph is an example of confounder. Variable is considered as a confounder if it's a common cause of both the exposure and outcome. In this example, we can see smoking can cause yellow fingers, and smoking can cause lung cancer. in the prediction model, if we forget to put smoking in the model, then we're going to generate a biased association between yellow fingers and lung cancer. In other words, yellow fingers can be predictor of lung cancer, but it's not causally related. So another scenario is about collider. A variable is considered as collider if it can be caused by both of the exposure and outcome. In this example on the right graph, so exposure is locomotor disease, outcome is respiratory disease. Both of these conditions can cause hospitalization. However, if we put hospitalization, this collider, into the model, then it generated biased association between locomotor disease and respiratory disease. From reading the model, we can say locomotor disease is a predictor of respiratory disease, but in reality, it's not because of a locomotor disease to cause the respiratory disease. So in summary, forgetting about confounders or we include colliders in the model can produce these biased association. They're still predictors, but they are not causal factors. They cannot serve as intervention targets. The predictions can still work well, but the models cannot interpret it causally. Next slide, please. Yeah. How can we address this issue? So we can use causal, or also called counterfactual prediction. When we talked about counterfactual, it refers to alternative scenario. So the counterfactual prediction actually refers to alternative prediction. The research question would be something like, how could the risk of dementia change if a person was prescribed metformin, a glucose-lowering drug, instead of the Eurocare? Let's think about it. If we use general prediction model, then we would develop a prediction model to predict the risk of dementia. And metformin or the Eurocare might be a predictor or not. So if we use counterfactual prediction, the research question would be how the risk of dementia would change if the person was prescribed metformin instead of the alternative scenario, Eurocare. So we can use other study design and techniques to address those confounding bias. A good example is randomized clinical trials. The randomization process can isolate the confounding and the bias. However, it's not always feasible. For example, the high cost, the ethical issues, as well as too short follow-up to generate sufficient number of outcomes. Causal inference has been widely used in observational data, but they have some limitations in methodologies. Usually, the standard causal inference method can only generate population-level average treatment effect of a single intervention. The causal inference framework integrating with AI actually offer us a great opportunity to study the individualized treatment effect of alternative scenarios or interventions. That's why we care about the causal prediction. I think that's it. Thank you.
Thank you very much. So we move now on to the next, which is Dr. Lee, and she's going to talk about the so-called p-hacking, which means you can torture the data until they will confess. And as we said before, you know, we were doing all this work trying to figure out the bias and working on the data, and we could test so many variables, so many confounders, and so on. So what are the hurdles of that?
Okay, thank you. Yeah. First of all, Mattia, thanks so much for having me. Also, thank you so much for coming out, you guys. After lunch, I hope you are not so sleepy. So that's why this very sensitive kind of a title can make you awake. So my talk today, it will be not directly, I will use AI, but I think the fundamental concept for the better AI. So you may already heard if you are research, you are doing research or scientific, the working, then p-hacking you may heard. Could you raise a hand if you have heard p-hacking? How about cherry picking P too, right? So what is a p-hacking? P-hacking is in a statistical test, in hypothesis test, when you have some scientific question can be laid out as a hypothesis test, and you test, continually you test, then you will get a p-value less than 0.05. P-value equal 0.05 is artificial threshold, and if less than 0.05, you are jumping out. You love it that one, saying that, yes, my scientific question is, you claiming the scientific statement is validated. That's the threshold. So this you have one data set, let's say, if you said your hypothesis is something outcome is differ by the gender, male and female. Oops, when you test it using t-test, whatever you do, p-value was 0.07. You are disappointed, okay, then let's move on to by testing by race and ethnic background. Oops, p-value equals 0.8. That's not working. Okay, so now move on to the maybe, eyeglasses people or no eyeglasses people. Let's do that. That's not. And then white t-shirts group first, the black t-shirts group, you test it again. Finally, p-value is 0.03. So then you're so excited and then you publish that paper because the p-value is less than 0.05. This is basically the p-hacking. And then why this is the problem? It is a p-value is probability, which contains uncertainty, okay? So if you do continually with the same data set, testing something, automatically someday or some of them will be by chance will be a p-value will generated as less than 0.05. So right now, currently in scientific field, we have a crisis of reproducibility or replicability. All this is a crisis. And even some psychology, behavior science, almost 65% of studies fail to reproduce. All those things. And even medical field, I don't think so this is also, we are immunized to this issue. So like this one, and then we are overly exaggerating about something effective or important or significant. So that is the main issue. And here I wanted to make sure that when it's not misleading, hacking is okay in my personal view. Hacking is, you have to hacking. If you have the expensive data, you have to hacking. The issue is the p-value. So all analysis, so make sure that p-value less than 0.0001 doesn't mean that your research is absolutely rigorous, your research has no problem, your research is absolutely has something important. You just, as a signal, you have to treat the p-value as a kind of indication of signals. Can you set next slide?
Yes. Bad advice.
Yes. Yes. So past 3 or 4 years, I gave a lot of ground round seminars about, p-value, rethinking p-values, because it's so widely inappropriately used. It didn't work. Still, I'm using it on campus. I see that one. Still, p-value is not correctly used. So now, even I gave it, advice. Past so many years, please use p-value appropriate. It didn't work. So now I'm trying to, from this year, I'm trying to give the better advice. So let's see how it'll work out, okay? So better advice number one is, it is a very common and normal to spend so much money and resources to collect research data, only to then use it, Excel spreadsheet, to manage and store your data set and analyzed by untrained and also underpaid student or research assistant. Second, continually love 1 asterisk, 2 asterisks, and 3 asterisks. Third, keep strong faith on the p-value less than 0.05. Last, persistent with the p-hacking that will pay off with a shining p-value less than 0.05. So this is my 4 bad advice. There are so many advices, but bad advice, number 4, I just picked up. So last one, next slide. Sorry that I have a multiple slide because I have a class at 2 o'clock, but I could not pass these opportunities because I know you guys will use a lot of data, and I have to give this message, deliver this message. So this one is my last one. We are living in an AI era. The AI is very promising. AI is so important. But please remember that AI is based on the data. If the data you are using for the developing prediction models, machine learning approach, or deep learning approach, whatever, generative AI, all those things is the data we feed, right? If data is so unstable, not high quality, the model predicting or beautifully predicting is absolutely building the fancy house on the sand. So why this is happen? I think right now the cultures, all this in the cultures, we are so much focused on the productivity, and we don't have much time or we don't have energy to think of it being right, to have the maximum highest, high quality, to have to care about our collecting data. Okay, thank you.
Thank you very much. So before I move to the use case from our student, I just want to also excuse Dr. Leaf. She has to go earlier maybe because she's teaching these important things to the students. So if she disappears, it's not that because she doesn't like us, but she's serving the purpose. Sarah.
Good afternoon, everyone. So we heard now about a lot of perils, but what do we do to try to avoid them? What do we do to make researchers aware of these perils? So we're coming up with a cookbook for helping researchers who are doing AI research. This reporting tool is going to be the first defense to avoid some of the perils, such as p-hacking and bias and possible harm in implementation. And so right now the working title for our guideline is going to be PRECOG, Prediction of Counterfactuals Guideline. So even though there are some reporting guidelines out there and there are some for prediction modeling, there isn't one specifically for counterfactuals and causal inference from prediction models. And as Dr. Guo described, there are some special things that we need to be aware of. And so with this guideline, we hope to improve the overall quality of studies, also transparency in reporting so that people who are reading the studies will be able to understand what the researchers actually did, the systematization of reporting items so that it's clear and organized when you're reading papers, and also the reproducibility, as Dr. Lee talked about. The reproducibility is a major issue, and also the validity of study design and results. And so the guideline development process that we're having right now consists of 2 major steps. And so in the first step, we're conducting focus groups, and we're having systematic reviews to develop the scope, definitions, and our initial reporting checklist. So far, we've had 6 focus groups with 27 participants from around the world with expertise in a variety of subjects, including causal inference, biostatistics, epidemiology, computer science, philosophy, nursing, informatics, and economics, because we want to know from methodologists what needs to be included, but we also want to know from people who are applying these kinds of models what needs to be included in studies when they're designing studies and also when they're reading studies. And so the second step, once we have our checklist based on all of the input from all of these experts, is an online Delphi study to consolidate the reporting checklist. And so then we're going to have input from even more experts that we wouldn't have been able to hear from otherwise, because we could have focus groups forever because there's so many experts, but we're going to have the Delphi study. So thank you.
Thank you very much. So now it's time to switch seats. I'm going to sit on your seat and you're going to come on stage. And it's time for questions. So we have a few prearranged questions, and then we will open the questions to the public.
Okay.
Any other questions from audience?
Okay, so now I get to interrogate you all. So, Dr. Candidate, what do you think about fairness and acceptability of complex AI models for the community? Yes, so, hello? Okay. So again, as I mentioned earlier, making sure that the data doesn't exacerbate the disparity in a particular community. So for example, my research is done among same gender-loving men, and here in Florida, same gender-loving men account for the highest HIV incidence and diagnoses. So as many of these panelists mentioned, you have to make sure that the data that you're collecting is not biased. So if I'm conducting a study that's wanting to look at behavioral or medication adherence among these individuals, I wanted to make sure that I have not only race and ethnicity collected, but I'm collecting the data from various sources, not only in the community, but also throughout the state of Florida. And when done correctly, that data can be used to improve targeted outreach for those high-risk groups. It can also be used to develop behavioral change intervention and messaging for these groups. Also, when you think of the acceptability piece, it's getting down to that community. So making sure that the outputs that are being put out by these models, that they're understandable by everyone. So if you're talking to researchers, the output is going to look different, but if you're going into a community and you're doing a town hall, how can you make that data acceptable to those who do not have a research background? But also making sure that even though a lot of the AI data focuses on historical data and looking at patterns and trends, also thinking about how we can use population data to better help us in our outreach efforts. Thank you, Dr. Candidate. Did any of the panelists have anything they'd like to add? No? Okay. Does anyone in the audience?
I can answer. It is not, but it is not done in AI as diligently as in other subfields.
And I do agree that what you described is correct. I think it applies to every reason.
Yeah, there is some evidence to what Dr. Marini said. For instance, we showed that take AI models that are trained on public data, like social media data. We ran a study and we were doing a systematic review. More than 30% of the studies don't even mention the ethical review, or at least, some kind of process that would exempt the research from being reviewed by an ethical board. So there is something that is cultural, and the culture has to change, and we know how to do good research. So that's, we have to embed that in the next generation research.
I believe that what you guys described today is great. We should talk about that more. But generalize it, not about AI.
Other questions?
Okay, so I'm going to go to the next question. Dr. Marini, let's suppose we have two diagnostic algorithms, one based on an interpretable model explaining disease biological mechanisms with an accuracy of 80%, and another one based on a black box model with accuracy of 90%. So if you had to choose, which one would you prefer to be used in clinical practice?
All right. First of all, the algorithm should help and not perform the diagnosis based on the technology that we have so far. They should help the doctors, but not take their jobs. So in general, I would say that for the diagnosis of my specific case, I would love to know the original data set for the AI to be trained on, to see how well I am represented in that data set. And if I'm very well represented, I might even choose the black box model for diagnosis. But that's on a case basis. In general clinical practice, of course, it would be, this is an if case, a what if scenario, it's a hypothetical question, so it would be better to go with the, in my opinion, with the lower accuracy, but interpretability, so not the black box model, to understand when the diagnosis is given, what is the reasoning behind the diagnosis, let alone the fact that 80 or 90% accuracy would be laughed at from any doctor. But again, that's my answer.
Thank you. Did any of the other panelists want to comment? No? Any questions from the audience? No? Okay. On to the next. So Dr. Guo, what are the practical challenges of developing causal prediction models? And can we really identify true causal effects from real-world data? Do we always need randomized trials to confirm?
So there are a lot of practical challenges actually running the causal prediction model. First of all, we need to really have the knowledge on the prior knowledge for the causality. We need to set up a causal framework, whether you believe the alternative scenario or the exposure of interest is really associated with the outcome. So building up on the causal framework, we need to draw the causal diagram and identify the specific causal machine learning functions. And I think that's one of the practical challenges that when we set up a causal prediction. So what's the next question? Sorry.
About can we really identify true causal effects from real-world data, or do we need randomized trials always to confirm?
Yes. So it's based on assumption. Yeah, we have assumptions for causality, such as the exchangeability, the consistency, and the positivity. If we believe all the assumptions make sense, then we believe it's highly likely that there's a causal association. So even though for randomized trials, it's no doubt is still the golden standards to test the true causal relationship.
Can I add to Dr. Guo's the comment? So even right now, I said people who come to the lab is sitting left side and right side, two groups, and if I plotted these two groups for their BMI value, for example, I think there will be a strong correlation or association is coming up. Even in the United States, cheese consumption will be associated with the suicide rate. So what happened here is, what we're doing is research correlation, association, that is confused with the causal relationship A caused B. So with this, Dr. Guo's point is the randomized trial, a prospective study, you can follow them, and then you can add the causal inference. But what we doing is real world data or retrospective data or the electronic medical record data. What we're learning is just association or signal or some hint. And then but somehow we tend to believe that when something A caused B, kind of a causal relationship. So that is the major issue. A lot of scientists, we are misinterpreted about the data. You see, New York Times, for example, it says some years ago, tomato, prevented GI cancer. That's a very sexy title, as articles. If you're looking at that one, what they do is you ask the people who had a cancer or no cancer divided, and then how much they consumed the tomato. That doesn't mean the tomato, the prevented cancer, the prevented incidence of cancer, but there is a simple association and simple correlation is somehow misconceived. So I want to just emphasize about Dr. Guo's point.
Does anyone have any questions? No? Okay. So Dr. Lee, do you think that the intrinsic ability of AI to test millions of concurrent hypotheses and fit data sets perfectly is going to make things worse with respect to p-hacking?
I think so. What I just had is almost same things. I believe that AI will be a great tool in the future for our scientific research, and it's a strong, strong tool, that's for sure. And then I also believe that AI can simultaneously 10,000 hypothesis testing without any hesitation who can do that one. But can you believe that one? I mean, I don't think the AI can be immunized by the p-hacking issues, multiple comparison issues. Today also we also fitted the very high throughput data set, and then we used just because too many variables in the model, so we put it like a 60 number of what the coveted is 60. We put that one just machine learning approach to select those variables. We didn't think what variable pre-specified what variable should be included. We just dump on that one, and it's collected some variable stage, and then also AACR stage, even basically same two similar the information, those things. So automatically computers is selected very important algorithm selected very important variables, but that doesn't mean that when two variables truly should be in the same algorithm. So AI has the tool, but the bottom line is it cannot be immunized. We cannot trust it automatically. We have to be very, very cautious about model building and then predictions. All what we worry about right now is also we have to worry in the future.
Thank you, Dr. Lee. Did any other panelists have anything to add? Okay, so does the audience have any questions?
I have a question for Sarah. So as a student who is also developing the guidelines, what is your take about having a guideline, having a tool like PRECOG or all the other reporting guidelines that are out there? How can these help a researcher and a student that is becoming a researcher in their path, in their career, in the way in which they can frame their ability to do proper research and work also on the integrity of research?
So there are a couple of things. In terms of designing studies, I think that guidelines sometimes might help you remember something that you wouldn't have thought of, or they're more specific. Also, when you're writing your papers to share with other people, you may be tempted to leave certain things out that you think like they don't need to know this, but the guideline helps you remember that, oh, by sharing my method or by sharing what I did here, that's going to help with the reproducibility, that other people could then, conduct similar studies or, different studies to compare. Also, it's really helpful when you're reading other people's studies, when you're reading articles. So when you as a student are trying to, do a literature review, or even when you're doing like peer review for a journal, sometimes it's like, okay, well, this sounds good, but how good is this study really? And using this guideline, you can look and you can actually go through each thing. So you can go through like what kind of data set did they use? What was the study sample? How did they measure their outcome? What were the methods they used? And you can see, okay, they included this, they didn't include this, and you can kind of objectively see really clearly how good or not the study is.
Thank you. Are there any comments from the audience? Well, we are 3 minutes late.